Um, Dr. Poornima offers tailored expertise in cardiography, cardiac PET, and nuclear cardiac imaging. Her dedicated focus extends to women's heart health, with a particular emphasis on pregnancy-related cardiovascular disease. Today, her keynote presentation will be about evolving knowledge of cardiovascular disease in women. Let's give it up for Dr. Poornima.
Can you hear me?
Yes, we can hear you clearly.
All right. Well, thank you all. Thank you to Dr. Brower, to the Achilles Network for inviting me to participate in this presentation and share my knowledge about cardiovascular disease in women. As you can see, I'm the director of the Women's Heart Center, and this is an area that I'm very passionate about. And I wanted to first let you all know that tomorrow is Go Red for Women Day. And this is the Go Red for Women movement started more than 15 years ago, essentially to bring the awareness that cardiovascular disease is indeed the #1 killer of women in the United States. So typically a day in February is designated as National Wear Red Day, and that's tomorrow. So love to see you all in red tomorrow. I may not see you, but please do wear red anyways. So thank you again for allowing me to participate in this session. So when we talk about cardiovascular disease, I just wanted to sort of give you an overview of what comprises cardiovascular disease. You will hear these different terms when you talk about heart disease. And the first and foremost is coronary artery disease or ischemic heart disease, which is essentially referring to blockages in the arteries that supply the heart muscle. Then comes congestive heart failure, which is a weakening of the heart muscle itself, such that it is unable to pump the blood adequately. High blood pressure, I'm sure everybody is familiar with. Stroke, peripheral vascular disease, which refers to essentially blockages in the other arteries of the body, similar to the coronary arteries. And the pathogenesis and the pathophysiology is very similar, such that patients who have coronary artery disease are also prone to have peripheral vascular disease. And of course, stroke itself is caused by blockages that supply in the arteries that supply the brain. And then cardiac arrhythmias, which are essentially irregular heart rhythms. And then valvular heart disease, because the heart itself has 4 valves, and that can get affected by different conditions, starting from congenital malformations to infection, and of course, degeneration that can happen just with age. So if we just look at the burden of cardiovascular disease in the United States, there are about 60 million women, about 44% of the overall population, who are living with some form of heart disease. And it is, like I said, the #1 killer of women in the United States. And most importantly, it can affect women at any age. It accounts for 1 in 5 female deaths, and it is right above cancer. And in fact, cancer is catching up very closely to cardiovascular disease. But most importantly, despite the Go Red movement and all of the discussions that is in the public sphere about cardiovascular disease, every 10 years, the American Heart Association actually conducts a survey, a national survey of women to understand their awareness about cardiovascular disease. And most recently, the survey was conducted in 2019, and less than half of women who participated in the survey actually identified cardiovascular disease as the #1 killer. So while breast cancer is the foremost in every woman's mind, and everybody knows that they have to get their mammograms after a certain age on an annual basis, there is still very little that is being done in the public sphere to increase the awareness that cardiovascular disease is indeed the #1 killer. So as you can see here, compared to several other industrialized countries, the United States, both men and women, the death rates per 100,000 population from cardiovascular disease is still quite high. And on the right, you have a graph showing the trends in cardiovascular mortality for both men and women. There was a nice sharp drop in the mortality related to cardiovascular disease in the early 2000s, but we've seen that that trend is being reversed in both men and women. And the reasons for that include the increased obesity epidemic and more recently, COVID related cardiovascular deaths as well. So, the first and foremost we'll talk about is ischemic heart disease or coronary artery disease, which, as I mentioned, is related to abnormalities that occur in the arteries that supply the heart muscle. And the most common term that you will hear about is a heart attack, which, as I said, includes all the abnormalities that relate to the arteries that ultimately lead to a dysfunction of the cardiac muscle. And it is a primary condition that affects more than millions around the world. But as shown in the graph on the right, when a woman develops a heart attack, the likelihood that she will die after that first heart attack is higher than a male of the same age. And specifically in Black women, this incidence is even higher. So, not only is there a higher incidence of death after the first heart attack, but more women than men also develop some of the adverse consequences related to the heart attack, such as congestive heart failure. So, both the incidence of heart failure and mortality is higher in women, but more specifically in Black women. We think that there may be some biological differences that may result in some of these outcomes, but there are clearly several social determinants that are also responsible for this. More importantly, delayed recognition of symptoms by patients as well as by the medical system may be also contributing to these adverse events that we're seeing in women compared to men. So I'd like to go back and just discuss what causes these blockages and how do they develop over a period of time. And this is what is shown here. This is essentially a cross-sectional figure of an artery, of an arterial wall. And you can see on the far left how a healthy arterial wall should look. And then the first stage of atherosclerosis or plaque deposition in the arteries is essentially what's called as a fatty streak. And in that fatty streak, you have cholesterol deposits that go into the arterial wall, and it is covered by some smooth muscle cells that ultimately grows over a period of time and ultimately undergoes what's called as a plaque rupture or erosion, and a blood clot forms on top of that, leading to an acute obstruction of the blood vessel itself. When there's an acute obstruction in that blood vessel, that is essentially what causes an acute myocardial infarction or a heart attack. So, this is the most common pathogenesis of a heart attack. But in women, heart attacks can occur by multiple other mechanisms as well. So, on the far left, you see the atherosclerotic plaque rupture on the far left top corner. But there are other mechanisms by which women can have heart attacks, one of which is by just separation of the arterial wall itself, and that is what is called as a spontaneous coronary artery dissection. Women tend to have hypercoagulable states, which is essentially high coagulation states due to multiple conditions, including taking oral contraceptive pills or some other inherited conditions, which are more common in women. Drug induced can be taking things like cocaine or even stimulants such as amphetamines. Vasospasm, which is essentially where the artery goes into constrictive mode for no particular reason, seems to be more common in women. And finally, autoimmune, which is an inflammatory state that occurs in the whole body, such as in conditions such as systemic lupus erythematosus or SLE, rheumatoid arthritis, systemic sclerosis. These conditions, autoimmune conditions, are more common in women, lead to increased inflammation, which actually promotes development of atherosclerosis. So these are other mechanisms by which women develop heart attacks more so compared to men. So these unique risk factors are listed in this figure here, but there are also some biological conditions that occur in women that make them perhaps more prone to a heart attack. And these include a thinner heart muscle, the actual vascular tone of the arteries is known to be different compared to in women compared to men. And there are actually abnormalities that occur in the small vessels of the heart muscle. So even though the large arteries may be okay, the small vessels may be abnormal, also leading to heart attacks as well as chest pain. So it's important to recognize that there are multiple factors that play a role in the presentation of cardiovascular disease in women. And the whole concept of ischemia with a non obstructive coronary artery has sort of become mainstream now with increased recognition that not all women who present with a heart attack actually need to have an obstruction in the artery itself. And this figure shows the large artery that supplies the heart muscle, which is the epicardial artery, but it breaks off into these little branches, which are finally called the capillaries, which really can be seen only on electron microscopy. And that's what comprises the microcirculation of the heart. And abnormalities in coronary microcirculation are actually more common in women compared to men. So, heart attacks in women can occur with no significant obstruction in arteries, and that is an increasingly recognized phenomenon in the last 10 years or so. So, moving on to the risk factors that really lead to atherosclerosis and lead to some of these abnormalities that we've discussed so far. I'm sure you've all heard about all of these conditions that lead to atherosclerosis and cardiovascular disease, which includes diabetes, blood pressure, cholesterol, weight, smoking. And of course, most recently, the American Heart Association has also added getting healthy sleep as one of the cardiovascular risk factors because patients with sleep apnea, as well as with sleep disturbances, seem to have a higher propensity for developing obesity and high blood pressure. So, really, if you can adopt these life essential 8, which includes sleep, the likelihood of cardiovascular disease is much lower. But again, there are some female specific risk factors that we absolutely need to be paying more attention to, especially in young women. And these are listed here. And most importantly, I think what has really come to the forefront in the last several years, based on years of research and increased recognition, is hypertension in pregnancy. And this includes 2 conditions, preeclampsia and gestational hypertension. But these other conditions are also now identified as cardiovascular risk factors. That includes gestational diabetes, preterm birth, small for gestational age baby or having a large gestational age baby, recurrent pregnancy loss that is spontaneous, polycystic ovarian disease, women who have premature menopause, that is menopause before the age of 45, and women who undergo fertility treatments with multiple hormonal injections which may actually increase their risk of cardiovascular disease in the future, especially if they have underlying history, such as a family history of cardiovascular disease. So, the common theme that seems to sort of unite all of these pregnancy related complications appears to be what is called as placental insufficiency. So, what research has shown us in the last several years is that in patients who have underlying cardiovascular conditions, including risk factors for cardiovascular disease such as diabetes, high blood pressure, obesity, etc., the placenta, for some reason, does not seem to develop normally, as a result of which the blood flow to the fetus is also impaired. And the woman, the mom, actually develops abnormal inflammatory signals in the body, which raises the blood pressure. So, abnormal placental insufficiency is thought to be sort of the baseline pathogenesis of some of these future cardiovascular problems. And studies such as this publication have shown that when you actually harvest this placenta and look at it under a microscope, you can identify anatomical abnormalities, vascular abnormalities, as well as a state of inflammation that really should not be occurring in a normal placenta. So, of course, a lot more research needs to be done to identify and really understand what is the process here. I think we are really at the tip of the iceberg right now, and there's a lot more to be learned about this condition. And all of this matters because one of the grim statistics that we all have to contend with now is that maternal mortality is indeed rising in the United States, and it is the highest in the developed world. And cardiovascular disease seems to be the large driver of this phenomenon. Now, the graph on the left shows that certain races, in fact, are again adversely impacted more so than others. And non Hispanic Blacks, especially, the maternal mortality is just skyrocketing. And this seems to parallel the rates of high blood pressure during pregnancy, which the figure on the right shows that any HTP is any hypertensive disorder of pregnancy. And that seems to be on the rise in the last several years. So while we know that obesity, high maternal age, pre-diabetes, and of course, somebody with congenital heart disease leads to adverse pregnancy outcomes, we now know that it not only leads to high maternal mortality, but it increases the future cardiovascular risk of the mom. So there's a higher risk of both heart attack, congestive heart failure, as well as stroke. So these are sort of the statistics that we have to contend with, and obviously invest more time and effort in trying to understand the problem and come up with potential solutions. If you examine the sort of continuum of a woman's life, I think it's important to understand that opportunities exist at every time point, starting from early childhood. We know that the rates of childhood obesity are on the rise. So while we talk about the life essential 8 as an adult, I think we have to start thinking about it in children. So rates of high blood pressure, obesity, diabetes, high cholesterol are all on the rise in children in the United States. So if those could be addressed right then the likelihood that the woman would go into adolescence healthy is much higher. And therefore, when they go into pregnancy, the likelihood that you can potentially avoid adverse pregnancy outcomes, at least modifiable outcomes, is higher. And within pregnancy, if they do have these problems, then paying increased attention to those maternal conditions and making sure not only do they have a healthy pregnancy outcome in terms of the fetus or the child, but also paying attention to the mom in the postpartum phase, such that her cardiovascular risk is continued to be addressed so that she can go on to midlife and ultimately older age, potentially preventing adverse cardiovascular outcomes. So really, there's opportunities that exist at every one of these time points. But of course, if you look at that figure and look at the foundational determinants of cardiovascular health, you absolutely have to acknowledge that there are several social determinants that play a role. And this whole concept of intersectionality has come about where we understand that an individual has various identities, and those multiple identities actually intersect, leading to health disparities, such as some of the data I showed before regarding race. And so if obesity affects African Americans more so, Blacks more so, and they are also more likely to develop high blood pressure during pregnancy, it's important to come up with strategies to identify this condition early on and impact it meaningfully, such that, as I said, the woman does not enter the pregnancy with this heightened sort of risk. So, sort of summing up, cardiovascular risk factors in women, I think you have to almost think of about it in multiple steps. So, at the core of it is the traditional risk factors. So that includes the diabetes, the high blood pressure, high cholesterol, obesity, smoking, and of course the disparities that may occur just in those traditional risk factors. Then you come to the next circle, which is a female predominant conditions, such as rheumatoid arthritis or autoimmune conditions, migraines, lupus, depression, stress, which seems to affect and have a greater impact on women, compared to men. In fact, there are certain conditions called stress-induced heart failure or stress-induced cardiomyopathy that clearly predominate in women. 90% of stress-induced cardiomyopathy actually occurs in women compared to men. And then there are some female-specific risk factors that are listed in the outermost circle, most of which we have discussed already. Again, sort of to bring home why this is, again, a very relevant issue, we used to think that cardiovascular disease in women typically occurred after menopause when the effect of the hormones go away or the protective effect of the hormones go away. But what we are seeing more recently is that thanks to the higher incidence of, again, obesity, high blood pressure, diabetes at younger ages, the rates of acute myocardial infarction hospitalizations in the young, which is 35 to 54 years of age, is actually on the rise, and more so in women compared to men. So, which is it's shown on the left graph, which is the study, the ERIC study, is the atherosclerosis risk and community study. And of course, this study was reported back in 2018 and showed the data up to 2014. But we continue to see these adverse trends, especially among the younger age groups, which is very worrisome. And a more recent registry study called the Young and My study, which specifically looked at heart attacks in young patients, which is less than 50 years of age, showed that women, compared to men in this registry, were less likely to undergo coronary angiography or heart catheterization, less likely to undergo stenting, and less likely to be discharged on the guideline-directed medications that they are supposed to be on. As a result of it, they had a much higher all-cause mortality over a median follow-up of more than 10 years. So what we've talked about so far is mostly what are the risk factors that are unique to women, as well as what are the presentations that may be unique to women. But it's also important to understand that as a medical system, we also have a lot to do in terms of making sure that these disparities are addressed. And then moving on to, I guess, the final part of my conversation here, which is that, as was said at the beginning of this symposium, that we currently take data from men and essentially apply it to women, at least in terms of cardiovascular disease. That's the way it's been all along. Over the last several years, the enrollment of women in clinical trials has been slowly inching up. But even now, it's only about 35 to 40%. And some of the conditions, such as congestive heart failure, have barely increased in enrollment of women. So this whole thinking that research in men is equivalent to research or application in women really needs to change. And that is one of the main sort of areas that I think I try to promote as much as I can, is engagement of women in clinical trials. And in these clinical trials, why is that important? Why is it important, and why is it important to understand that you cannot translate results from men and just automatically apply it to women? There are indeed unique differences, even with the conditions that have been well studied over many years, such as high blood pressure. So the graph on the right shows you the difference in the prevalence of hypertension in between men and women, but also between different ethnicities and races. So again, one size does not fit all, and therefore the interventions and the research needs to be a little bit more focused and directed. And enrollment of a multiracial cohort in clinical trials is very important to get the results that can be applicable to all populations. The figure on the left, on the other hand, shows you that the effects of uncontrolled hypertension is not the same in men and women. So as you can see, this forest plot shows you that the likelihood of myocardial infarction or a heart attack, as well as the likelihood of stroke, is much higher in women who have uncontrolled hypertension. So for the same level of blood pressure, the effect of in women is much greater compared to men. So again, illustrating the fact that the same sort of research does not apply to all. Similarly, when it comes to simple things like interpreting the EKG, so the heart clearly the contraction of the heart muscle is based on electrical conduction that occurs within, and there's an electrical conduction system, and we look at that primarily in a very simplistic way through the EKG or an ECG. And even interpretation of the ECG, certain parts of the ECG should really be unique in men versus women. So there is something called the QT interval, which can actually vary based on hormonal influences. And even in women, depending on the stage of their menstrual cycle, there can be differences in the QT interval. So we often give medications that affect this QT interval. And yet, these medications, when they are tested in clinical trials, are not really studied separately in men versus women. So this sort of understanding should really lead us to, first of all, enroll more women in clinical trials, but also design studies such that that there can be at least some sort of stratified analysis, even of medication, both efficacy as well as adverse effects in based on gender. So just like I talked to you about the EKG differences, the response of certain therapies, which are been studied now for many, many years, when you actually look at them in a stratified population, the effects could be different. So rather than saying as a blanket statement that this particular treatment works for all, it's important to actually study it in the different genders and analyze the results separately. So, for example, catheter ablation of atrial fibrillation, which is a very common heart rhythm abnormality that occurs in both men and women. In this particular study, which again had larger number of men compared to women, they found that female sets was independently associated with more complications, more 30-day readmissions, and the efficacy was also not as good in women compared to men when you take into account some of these complications. Now, it's hard to say whether these are due to true biological differences in the actual problem itself, or is it just due to disparities in care? So, for example, women with atrial fibrillation may not get referred to catheter ablation until the very end of that stage of disease, as opposed to early on when men may get referred for the same procedure. So, is that the reason that they have more problems and do not have the same good outcomes compared to men? We don't really know the answer to that. So, there are disparities in care, delivery of care, but there may also be biological differences. And it is important to understand those differences. Atherosclerosis, which we talked about, which really leads to many of the problems we see in cardiovascular disease, also may have some gender-based differences. So in this study, which actually looked at the genetic differences in men versus women, they showed that genes were more active in women, that were more active in women were actually associated with the smooth muscle cells. As I told you at the beginning, smooth muscle cells are part of that atherosclerotic plaque. But in women, the genes associated with the smooth muscle cells were more active compared to men, where the genes associated with the inflammatory cells or the immune system were actually more active. So coming up with therapies that address some of these, even at the basic science level, may need to be gender-based, or even having that first understanding may help us direct therapies appropriately for the genders. Lipids or cholesterol abnormalities, again, occur in both genders, but we clearly know that there are hormonal influences on cholesterol. For example, estrogen is known to increase triglyceride levels and lower some of the other forms of cholesterol, such as a low density lipoprotein or the LDL. So this particular study showed that there are sex differences in the circulating lipid species. But as of now, therapies are typically not tested based on gender, and we sort of use one size fits all. In addition, again, gender differences in lifestyles and behavior may dictate some of these differences which we see in the cholesterol levels and the cholesterol particles. So again, it goes back to that what we talked about as intersectionality, where you need to factor in gender-based differences in lifestyle, and then comes the actual genetic makeup itself. So there are multiple factors that govern what determines outcomes, and understanding these factors is very important. So just to sort of summarize what potentially needs to be done in terms of research is at different levels. So the first thing is the study population. So obviously we need to enroll more women in clinical trials, but we also need to identify set specific cutoffs for physiological variables. When we study outcomes, when we study, different conditions, like we talked about, the EKG may be different in women versus men. The interpretation of that could be different. Body mass index, ventricular or the heart muscle thickness, is different between men and women. So these are all physiological or biological variables, and they must be analyzed based on gender. The study intervention or the drug that is being considered, the pharmacokinetics and the pharmacodynamics could be different in men versus women. That needs to be considered. Based on the prevalence of the disease in men versus women, separate sample size calculations need to be done. A specific condition called heart failure with preserved ejection fraction is actually more common in women than men. So the study population should really include in proportion to the prevalence of the condition. The study population should really reflect that. Clinical trial leadership, at least in cardiology, we talk about this a lot. If you look at the overall clinical trial leadership, the participation of women, still there's a lot of opportunity for improvement. Data and safety monitoring, set specific adverse effects absolutely need to be considered. And then we need to create an environment that facilitates enrollment of women in clinical trials, such as electronic enrollment, electronic follow-up, because young women or women in different phases of their life may have other responsibilities such that they cannot show up at the hospital for every single study visit. So all of these may go into actually creating an environment that can successfully recruit women in clinical trials, and ultimately the publication as well. So, of course, no conversation these days goes without discussing artificial intelligence. And just a recent publication that came out in one of our journals about how it can be used to study cardiovascular disease in women, because there's a lot of room for knowledge in this area. And potentially these large databases that currently exist can be harvested for this purpose. So I'll summarize that cardiovascular disease is indeed impacted by biological and social as well as gender differences. It is important to gain some mechanistic insights into female-specific risk factors, a big push for gender-based research, as well as health implementation efforts. And finally, health policy needs to change that actually impacts young moms so that maternal mortality rates in the United States can be impacted. So thank you again for allowing me to participate in this. And I'm happy to take any questions.
Thank you so much, Dr. Poornima. Take questions from the audience. Questions? Anybody want to ask a question? Run the mic over.
What exact parameters that you are taking from men that you are applying for women to see any kind of a correlation between the cardiotoxicity?
So your question is, are there currently parameters that we're looking at?
Yeah.
Yeah, so Right now, there are no studies that actually look at this in a gender-based fashion. Most of the time, what happens is it is a subset analysis that is done at the end. And depending on the number of women that actually are enrolled in the clinical trial, the study may not really be statistically powered to look for adverse effects specifically in women. So it starts with enrolling equal number of men and women so that we can actually study those adverse effects separately in women at the end.
Thank you.
Is there an opportunity for gender-specific drug indications? And if so, what would be on the top of your list?
Sorry, I just need to understand that question. So you're asking if there are gender-specific risk factors that need to be studied, or?
Yeah, yes, or I'm thinking if it would be worthwhile for a pharmaceutical company to develop an indication for female cardiovascular disease only. If so, what do you think would be the most important?
Yeah, that's a great question. So I would say there are several conditions that are unique to women. Certainly, the pregnancy-related cardiovascular issues is on the forefront of research, but I would consider that as a foremost indication currently. But we do need to understand it first from a basic science concept so that we can develop therapies that can actually address this problem. Because honestly, I think with the rate of pregnancy-related complications that we're seeing, the graphs that I showed you about the increasing trend of events in young women, I think I foresee that that's only going to keep increasing. So something to address that problem would definitely be at the forefront.
We have a question online. Please discuss salt-sensitive hypertension and its differential role in women. Do you have a preferred treatment for SSH?
Yeah, so salt-sensitive hypertension as a category, I think is a little bit ill-defined, I would say. And the reason I'm saying that is, the role of increased sodium intake in as a cause of hypertension is, I think, well acknowledged and well known. In a clinical practice, I would say there is no specific population that we would test specifically for salt sensitivity. But on the other hand, we know that populations, at a population level, there needs to be certain groups, especially Blacks, South Asians, who are inherently known to be more salt sensitive, and therapies that are directed at them, such as diuretics, and of that specific diuretics, I think as first-line therapies for hypertension should definitely be applied. So in an individual level, we don't test for salt sensitivity, but in terms of patient populations, we certainly have that understanding and therefore would use preferentially agents such as diuretics.
Okay. Thank you so much, Dr. Poornima. The wonderful
Thank you.
talk. Let's give her another round of applause.